Why don't we take our seats and get started? We actually have a lot to do today. While everyone's getting seated, let me tell you the format today. My name is Will Seffler. I'm the Chief Scientific Officer, and the session today is we're going to review the early draft of the ADA EASD Consensus Conference on Management of Hypoglycemia. Our co-chairs are Dr. John Buse from the University of North Carolina and Melanie Davies, University of Leicester. And the format today will be each one will be presenting a certain section. What you'll find different this year, again, every 3 years we work with the EASD on this particular statement. First started in 2012, last one in 2015, but you can imagine the data to date and all the new information over the last 3 years, which is going to be incorporated in this particular document. Also, what's going to be different, it's not going to focus totally on pharmacologic management, psychosocial management, lifestyle, self-management, so that's going to be different. So the format today is they will present you in draft form the data and the slides and where the committee is going as far as treatment. I ask not that you do not take photos. This is draft. If the information will be available on the ADA website, they have the information. This is being webcast. You can review the webcast. If individuals are not here to hear it, please refer them to it. We will take public comment until 11:59 July 2nd. I believe that's DC time, John.
Yes.
Okay. So this is available for public comment, and again, no photos, but the webcast will be available. So without further ado, and we have a lot to cover, and at the end we'll have panel discussions, I'll turn it over to Dr. Davies.
So thank you very much, Will, and welcome to this session where we have the opportunity to present to you the draft ADA EASD consensus report on the management of hyperglycemia in type 2 diabetes. So these are my disclosures of interest. And as Will has already said, we would be grateful if you don't take photos of the presentation, but you will be able to access it via the webcast. So I'll give a brief introduction and describe some of the methods that we've used and the approach that we've used in terms of coming to this consensus. So the writing group is 10, sitting alongside me this morning, selected by the ADA and EASD. We have regional representation, so 5 from the US and 5 from Europe. And there was a deliberate choice with a spectrum of disclosures of interest with an emphasis on members with limited or no disclosures. We had 2 face-to-face meetings, one in Windsor in the UK in January of this year and a second one in Washington in April. And leading up to that and after that, we've had fortnightly teleconferences. And myself and John Buse are the co-chairs, and then we've had 4 pairs of section authors, because at the early meeting in Windsor, we talked about the outline of the document and went through 4 sections, which we'll go through in much more detail. Also, this time, there was a quite robust approach to obtaining the evidence, and the evidence review informed the content of the document, and I'll come back to that in a little bit more detail. So this is the team, and it feels quite like a team now after working together for over the last 6 months. So you can see myself and John as co-chairs. Judy Fradkin from the National Institute of Diabetes and Digestive and Kidney Diseases, and Apostolos Tapas from the Aristotle University, Thessaloniki, Greece, were the section leads for the introductory section around the rationale. And then we have Peter Rossing from the Steno Diabetes Centre, Copenhagen, and Deborah Wexler from the Massachusetts General Hospital and Harvard Medical School, who are looking at the personalised approach. Walter Kernan from the Yale School of Medicine and Geltrude Mengroni from the Catholic University of the Sacred Heart in Rome will go through therapeutic options. And then finally, in terms of strategies for implementation, it's David D'Alessio from Duke University and Chantal Matter from Leuven in Belgium. And then John drafted the section and will present the section on gaps and future direction. So this is just two photographs from our meeting in Windsor and Washington, and it's actually been a fantastic experience working with the 10 of us. I think we've grown to be friends over the last 6 months and have a huge respect for each other and have learnt a lot, I think, during this process. And we've had fantastic support from the ADA, in particular Erica Berg, who was at the Windsor meeting, and now Mindy Siracco, who's worked with us since then up until the presentation today. So during the session this morning, we'll go through in a little bit more detail each of these sections, the rationale importance of anti-hypoglycemic treatment, the personalised approach based on patient characteristics and comorbidities, therapeutic options, and then strategies for implementation. It's important to say that our approach was to accept the 2015 edition of this position statement as our starting point. But we did an evidence search after that point. So to identify the newer evidence, we conducted a search on PubMed for randomized clinical trials, systematic reviews and meta-analysis published in English between January the 1st of 2014. So we wanted to make sure that we got things that may have not quite got into the 2015 consensus statement, and right up until the end of February of this year. Eligible publications examined the effectiveness or safety of pharmacological or non-pharmacological interventions in adults with type 2 diabetes, and the reference lists were scanned to identify additional articles relevant to the subject. We will publish the details of the search in any publication in a supplementary appendix, so it will be searchable. And then following that, we grouped the papers according to subjects, and then these were available to each of the section authors to inform the consensus recommendation. So this is probably too small for you to read, but it just gives you the detail of the search strategy. So we identified initially around 6,873 papers, and after a review of the title and the abstract selection, that was down to 698. A further 219 were excluded by full text screening, and that left us with around 479 papers, which were then grouped for each section, and this was the newer evidence review that informed each of the sections, and also, obviously, if we identified any records through expert opinion, they were also included. So I suppose the key points to emphasise when you see the presentation is that the update has been informed in a structured way by evidence generated over the last couple of years. There is a greater focus, I think, on lifestyle interventions with increased emphasis on weight loss and obesity management, including metabolic surgery. There's also a focus on patient-related issues and self-management, which we believe have a major impact on the success of any pharmacological interventions. And there are preferred choices now for anti-hypoglycemic agents, which is driven by the new evidence, particularly from the cardiovascular outcome trials, but also from areas of major clinical need, particularly weight and hypoglycemia. So this is, I suppose, the core principles of care that we've articulated in our document: the patient at the centre, with the goal of preventing complications and optimising quality of life. An approach that starts with assessing key characteristics and then has ongoing review and agreement of management plans. We will undertake a review process, and this is one part of that. So the ADA and EASD have nominated reviewers, including patient and professional organisations. The individual authors also selected 2 reviewers, and this is also going to the ADA's Professional Practice Committee and Executive Board and the EASD's Committee of Clinical Affairs. But we also want to hear from you, and so we will receive feedback from this presentation, and the reviewers' comments will be reviewed by the writing team and will inform a draft which will be submitted for publication to Diabetes Care and Diabetologia, and the final consensus will be presented at the EASD on October the 5th. So this is a consensus report. Our draft recommendations will be reviewed by individuals and organisations, and suggestions incorporated. During the presentation, the nearly 200 references which are included in the manuscript are not listed on the slides. That's just a pragmatic decision for the presentation today. However, although this is evidence-based, the recommendations presented are the opinions of the writing group, and not everybody agreed with every point. But what we did agree, as a point of process, that we would vote on areas of disagreement and proceed on the basis of a supermajority. So you can take a photo of this slide, and this is how you can contribute to the review process. And John will also show this slide right at the end for your information as well. So I would like to acknowledge the support that we've had, both from the ADA, particularly Will and colleagues Erica and Mindy, who've been absolutely fantastic. Also the EASD, David Matthews in particular, and Petra Neiman and Mary Hatter, but also from my team, Mike and Charlie, who helped design some of the figures and graphics that you'll see later. And with that, I'd like to hand over now to Judy Fradkin, who's going to take us through the beginning of the document. Thank you very much.
Thank you, Melanie, and it's a pleasure to be here today to discuss the rationale of anti-hyperglycemic therapy with you. I have nothing to disclose, but I do want to emphasize that my input into this consensus report is from my own perspective, and the report does not reflect the view of the NIH or the U.S. government. The goals of diabetes care are to prevent both short and long-term complications and to improve patient well-being and quality of life. Preventing complications requires control of glycemia and cardiovascular risk factor reduction. A proactive management plan for the control of glycemia, lipids, and blood pressure should have defined goals and targets. Glycemic control yields immediate benefits in reduction of symptoms such as thirst, polyuria, blurred vision, and fatigue associated with poor control. But beyond immediate symptom relief, substantial microvascular benefits emerge and increase over time. The evidence that the burden of microvascular complications of diabetes can be significantly reduced by early rigorous therapeutic intervention is unequivocal. Risk reductions of 50 to 76% were seen in type 1 diabetes patients studied in the DCCT. The UKPDS confirmed the importance of glycemic control for microvascular risk reduction in type 2 diabetes. Epidemiologic analysis of the UKPDS data showed that for every 1% reduction in A1C, the relative risk for microvascular complications decreased by 37%. The greatest benefit came from improving control in those with the highest A1C levels who were at the highest risk of complications. Because macrovascular benefits emerged after the randomized intervention period, there is uncertainty regarding macrovascular benefits of blood glucose control in type 2 diabetes. Providers and patients must jointly establish glycemic goals, taking into account individual preferences and factors. Despite controversy about the goals for many or most patients, there's general agreement that glycemic targets should be individualized, and also general agreement on the factors to be considered in individualizing goals. Thus, more stringent goals may be recommended if it can be achieved safely and with an acceptable burden of therapy, and if life expectancy is sufficient to reap the benefits of type glycemic control. Less stringent control may be recommended if the life expectancy of the patient is such that the benefits of intensive control may not be realized, or if the risks and burdens outweigh the potential benefits. The focus of this consensus report is not on what an individual's glycemic target should be or on how to select individualized goals, but rather on how to achieve the patient's individual glycemic target, taking into account patient factors and preferences and the ever-increasing choice of therapies available for glycemic control. Glycemic control is primarily assessed with the A1C test, which was the measure studied in trials demonstrating the outcomes benefit of glucose lowering. The performance of the test is generally excellent for certified assays and laboratories. As with any test, the A1C has limitations, particularly in people with conditions that alter red blood cell turnover, such as anemia or chronic kidney disease, or if an assay with interference from a hemoglobin variant is used in a carrier of that variant. When there is a discrepancy between the measured A1C and glucose levels, consideration should be given to the reliability of the A1C assay in that patient. Self-monitoring of blood glucose can help people on insulin with self-management and medication adjustment. Self-management plans should be individualized and the data used by the patient and the healthcare team in an effective and timely manner. Routine clinical monitoring is of limited clinical benefit in those not on insulin and adds burden and cost. The role of newer technologies, such as continuous glucose monitoring in type 2 diabetes management, remains to be established. Large proportions of the population with type 2 diabetes are not at their therapeutic goal. Thus, it is imperative that we develop improved approaches to therapies and that we empower patients and providers to effectively use the increasing number and variety of tools available to achieve glycemic control. Lifestyle remains the foundation of therapy for both blood glucose control and cardiovascular risk reduction. We know from Look Ahead and other studies that behavioral therapy targeting weight loss can reduce the need for medications to control blood glucose, blood pressure, and lipids, and yield numerous other benefits, such as improved quality of life. Yet this essential component of diabetes care remains challenging to implement. Blood glucose medications differ in their benefits, risks, costs, and ease of administration. Tailoring their use based on patient factors and preferences is a major focus of this report. Metabolic surgery also improves blood glucose control with reduced need for anti-hyperglycemic therapy. The ever-expanding array of therapeutic options and new information on benefits and risks of therapeutic modalities increases the complexity of patient-centered therapeutic decision-making. This report provides up-to-date information on the benefits and risks of therapies and guidance on when and how to deploy them, ensuring that patient characteristics and preferences are central to therapeutic decision-making. And now, it's my pleasure to turn it over to my colleague, Apostolos Siapas.
Thank you, Judy. Now, in my presentation, I will highlight the core principles of diabetes care as they are presented in the joint ADA-EASD consensus report for management of hyperglycemia in type 2 diabetes. These are my disclosures. As presented by Judy, goals of diabetes care are to prevent short and long-term complications and optimize quality of life. The current consensus report supports the use of a plan, do, check-act cycle for implementation of effective patient-centered diabetes care. In this report, patients' individual characteristics and preferences remain central in the therapeutic decision-making to inform individualized treatment goals and strategies to achieve those goals. The presence of specific comorbidities or clinical characteristics of the patient, like age, body weight, or HbA1c, as well as the characteristics of individual agents or drug classes, including side effects, complexity of regimen, or effect on HbA1c, or incidence of hypoglycemia, are explored during a patient-centered deliberation between patient and clinician. We underline the role of shared decision-making to present information and options in an understandable and actionable form to cultivate the patient's ability to give voice to which choice is best for them, or to establish an empathic conversational environment through which the individual with diabetes and their clinician think and talk through how to address the problems of living with diabetes. This can be facilitated by means of decision or conversational aids, which have been shown to improve patients' knowledge, satisfaction, risk awareness, decisional conflict, and involvement. And although there is still little evidence supporting the routine use of shared decision-making at the healthcare system level, there is an ethical imperative for clinicians to support the autonomy of patients and support the patients while making decisions together. Similarly, patients should be offered access to diabetes self-management education and support programs in group or individual sessions with trained educators that promote healthy eating, physical activity, good medication taking behavior, and increased self-efficacy. Current evidence supports the favorable effect of theory-based diabetes self-management education and support programs with structured curricula and contact time of at least 10 hours on HbA1c, hospital admissions, cost, and even risk of all-cause mortality. The consensus report also stresses the importance of a pragmatic management plan with specific, measurable, achievable, realistic, and time-limited goals that can be implemented in real clinical life to ensure high-value, kind, careful, and minimally disruptive care. We all know that this is often challenging because of the multimorbidity and associated polypharmacy people with diabetes often live with. And determining what is the best management decision for a patient requires often consideration of everyone's personal, social, and biomedical context, what he or she values, the reason he or she values the available options, and the relative contribution of each option in terms of benefits, harms, costs, and inconveniences. Now, high-value care is also challenged by reduced medication adherence. Existing evidence supports that at least 30% of patients are discontinuing their agreed treatment, a finding that applies to almost all agents, although there are slight differences and variations between individual classes, and which is consistent both in randomized clinical trials and in observational studies. Hence, it is important to ensure ongoing monitoring and support of patients that includes monitoring of achievement of all therapeutic targets and not just glycemic control, as well as of well-being of patients. Moreover, it's important to be vigilant not to delay initiating or intensifying therapy when indicated, a phenomenon known as clinical inertia. Inertia may be considered in three areas. The first is overestimation of care provided. Healthcare professionals are often overestimating their adherence to guidelines or the care they provide, and they are also often providing soft reasons to avoid intensification of treatment, including a perception that overall care of their patients is improving and that there is non-adherence among patients and concerns about results from trials. Finally, lack of training is a further reason of inertia, and many physicians lack the appropriate education and training needed to attain therapeutic goals. Finally, decisions and management plan should periodically be reviewed and revised if necessary based on mutual agreement. All in all, the report addresses the approaches to management of hyperglycemia in adults with type 2 diabetes with the goal of reducing complications and maintaining quality of life. The core principles of how patient-centered care can be achieved and are summarized in the figure presented. Deborah and Peter will highlight the implementation of this personalized approach in the context of comprehensive cardiovascular risk management and presence of comorbidities. Thank you very much.
Good morning, I'm Deborah Wetzler. Peter Rossing and I will present the next section of the talk on how to incorporate patient characteristics and comorbidities into this approach. I have no disclosures, and Dr. Rossing's disclosures are listed below. So again, we're going to focus on this first orange box in the framework, how to incorporate atherosclerotic cardiovascular disease, including heart failure and chronic kidney disease, into the approach while keeping in mind other clinical characteristics that remain important, as well as patient factors we just heard about. I do want to emphasize at this early stage that the foundational therapy of this approach remains metformin. There's been a lot of talk about metformin at this meeting, and this group recommends that that continue to be the case. 70% of patients in all the cardiovascular outcomes trials or more were on metformin, and it remains very evidence-based. In addition, comprehensive lifestyle management, including weight management, physical activity management, and dietary approaches, are the sine qua non of diabetes management and must always be readdressed at each stage. The first step, however, in this new approach is really to assess the presence of cardiovascular disease, because the presence of cardiovascular disease is a compelling indication for the selection of certain glucose-lowering drugs. And we've sort of given cardiovascular disease two flavors in this approach, with sort of one approach perhaps when atherosclerotic cardiovascular disease predominates, and the other when heart failure predominates. And so what's new since 2015 is that we recommend that these comorbidities be considered first and foremost because they do influence the choice of a particular glucose-lowering medication. And the recommendation is that among patients with type 2 diabetes with established atherosclerotic cardiovascular disease, sodium glucose cotransporter 2 inhibitors or GLP-1 receptor agonists with proven cardiovascular benefit are recommended as part of glycemic management. Important considerations to keep in mind and that we kept in mind in evaluating the evidence is that atherosclerotic cardiovascular disease is defined differently across trials. All trials enrolled those with established cardiovascular disease, patients with a history of heart attack, stroke, or a revascularization procedure, and also included those at very high cardiovascular risk, and that was defined differently in different trials. I think we've become used to thinking of patients with diabetes as having diabetes as a cardiovascular risk equivalent. And I think what's important to note is these were not just patients with that level of risk. These were patients at much elevated risk compared to the vast majority of patients with type 2 diabetes. It's also important to keep in mind that each cardiovascular outcomes trial, while large, is but a single experiment. And unfortunately, an experiment that's unlikely to be repeated given the cost and complexity of these trials. And so while those trials were well conducted and rigorous, there's sort of one trial to look at, and we don't have the benefit of replication. Finally, it's not always clear whether differences in trial findings within a medication class are related to the design of the trial, things like duration of follow-up, inclusion and exclusion criteria, or due to true differences in the individual medications. And so we sort of read into them and try to interpret these data, but it's just important to consider that. And as a result, when evidence suggests a hierarchy, we noted that. So if the preponderance of evidence is in favor of one, we have called that out. So let me turn now to the situation in which atherosclerotic cardiovascular disease is the predominant cardiovascular condition. If atherosclerotic cardiovascular disease predominates, we recommend starting either a GLP-1 receptor agonist with proven cardiovascular benefit, favoring liraglutide over semaglutide, and then over exenatide, long-acting, or alternatively, an SGLT2 inhibitor with proven cardiovascular benefit, recommending empagliflozin over canagliflozin. And these recommendations are based, of course, on the trials. LEADER, which was the trial of liraglutide, in which the primary outcome of cardiovascular death, non-fatal MI, or non-fatal stroke had a hazard ratio of 0.87 relative to placebo, with a number needed to treat of 52 over 3.8 years. And the EMPA-REG primary outcome, which showed a hazard ratio of 0.86 for the primary outcome of cardiovascular death, non-fatal MI, or non-fatal stroke, with a number needed to treat of 62 over 3.1 years. Important to keep in mind caveats as well as some questions. So it's very important to remember that there was no evidence of cardiovascular benefit seen in those at lower cardiovascular risk. Patients at low risk were not included in the trials, and in trials where patients at higher and lower risk were sort of broken out, patients without established cardiovascular disease had hazard ratios that crossed 1 for these outcomes. So there really was not evidence of benefit. And then an important question that remains, of course, is although it can be tempting to combine an SGLT2 inhibitor and a GLP-1 receptor agonist, this is an expensive and complicated combination, and it has not been tested in long-term cardiovascular outcome trials, and there's no evidence of benefit or additional benefit from a cardiovascular perspective for that combination of drugs. Finally, just to be complete in the discussion of cardiovascular outcomes trials, I do want to note and remind everyone that DPP-4 inhibitors have been tested in cardiovascular outcome trials, and those trials demonstrated safety, but not benefit. Let me turn now to my colleague, Dr. Rossing, who will carry us through the rest of this discussion.
Thank you. Now I'll address heart failure. Heart failure is a frequent, it's a fatal, but unfortunately often forgotten complication in diabetes. And it was also forgotten when FDA mandated guidelines for how to treat or test new glycemia-lowering agents. On the other hand, we felt we should not forget about heart failure, and we thought that the data from the studies were quite compelling. So therefore, if heart failure predominates, we suggest that you should consider SGLT2 inhibitors as a part of treatment strategy. The rationale being that for patients with type 2 diabetes, they are at increased risk for heart failure, both with reduced or preserved ejection fraction. And there was significant and consistent reductions in hospitalization for heart failure in the SGLT2 inhibitor trials with empagliflozin and canagliflozin. There's of course the challenge that this was secondary outcomes, and the trials were not designed to adjudicate heart failure in the way that heart failure studies are usually conducted. Another issue is that the majority of the patients at baseline did not have heart failure. 10 to 15% of patients in the SGLT2 inhibitor trials had heart failure at baseline, but also these subgroups had a benefit in the outcome. So you can say that we recommend that you use an SGLT2 inhibitor in patients with heart failure. Alternatively, because for many patients SGLT2 inhibitors are not indicated because of the label and because of impaired renal function, we suggest that you use a GLP-1 receptor agonist with proven cardiovascular benefit. Then we suggest that if you are still not at target, then you should avoid TZDs because of the risk for fluid overload. And you could then consider, if needed, to combine the SGLT2 or GLP-1 receptor agonist, although, as stated, we don't have specific cardiovascular outcome data on this combination. Or you could use a DPP-4 inhibitor if you are not on a GLP-1 receptor agonist. And we point out that saxagliptin has unfavorable data on heart failure. Alternatively, add insulin or sulfonylurea. And this is from the EMPEREC trial, just to remind you, on the data on hospitalization for heart failure, where there was an impressive 35% reduction in hospitalization for heart failure. And in the CANVAS trial, there was a very similar finding in a reduction in hospitalization for heart failure. And just to show you the leader data, where there was not a significant effect on heart failure, but an overall cardiovascular beneficial effect. Here with a 13% reduction in the hospitalization for heart failure, but not significant, as pointed out. Then we point out that in patients with chronic kidney disease and high cardiovascular risk, it is safe to use GLP-1 receptor agonist and SGLT2 inhibitors, although there are some requests for dose reductions. And as I mentioned, there's some consideration to the level of GFR, particularly in relation to the SGLT2 inhibitors. We also note that several of these agents have demonstrated renal benefits and cardiovascular benefits in this population, and therefore could be considered as part of treatment. But I'd like to say that the recommendations here for heart failure and in relation to kidney disease are softer than compared to the initial ones presented by Deborah. In relation to level of kidney function, we suggest the following considerations. First of all, you note that it's different from one country to another. What is actually the level of GFR that you can use the different compounds in, and it's also different between classes. So we will need to pay attention to this. But most SGLT2 inhibitors, they are registered for glucose lowering in patients with a GFR above 60 or somewhere above 45. And with declining renal function to below 60 or 45, you should stop these agents according to the decline in glucose lowering effect. But in the cardiovascular outcome trials, they actually included patients with a GFR of down to 30. And in some countries, like Canada, that's now allowed to use SGLT2 inhibitors down to that range. And there was the same effect, not on glucose, but on the cardiovascular outcome in patients with GFR in the range of 30 to 60. And there was no excess of side effects in that population compared to those with preserved renal function. For GLP-1 receptor agonists that could be used if SGLT2 inhibitors are not accepted because of the GFR level, well, with declining GFR, there's been noted an increase in the gastrointestinal side effect, and there's limited evidence in end-stage kidney disease such as dialysis patients. And as mentioned, there are also these important secondary and interesting outcomes in terms of kidney disease. Although we note them, we don't recommend these agents for kidney protection at this stage. Ongoing trials will address this, but this is from the EMPEREC trial, where a reduction in albuminuria and progression of heart renal endpoints was demonstrated with a hazard ratio of 0.54, as you can see, with empagliflozin compared to placebo. And in the CANVAS trial, also a significant effect on both albuminuria and progression of kidney disease were noted. And for the LEADER trial with GLP-1 receptor agonist and in other trials, it was demonstrated that GLP-1 receptor agonist can also have an effect on kidney outcome, but this was mostly driven by an effect on reduction in the progression of albuminuria. So we conclude that given the new evidence of outcome benefit with the use of specific antihyperglycemic medications in patients with established atherosclerotic cardiovascular disease, it's an important early step in the management to consider the presence or absence of this atherosclerotic cardiovascular disease or heart failure when you address treatment need. And in the patients with atherosclerotic cardiovascular disease, the studies have demonstrated a benefit on cardiovascular outcome, and some GLP-1 receptor agonists and SGLT2 inhibitors are recommended in these patients. And then hospitalization for heart failure was reduced consistently in the SGLT2 inhibitor trials, but it was a secondary outcome. And as mentioned, there are ongoing studies to address heart failure as a primary outcome with these agents, and the outcome of these trials will address and inform us further. But to summarize, the first thing to consider is whether you have atherosclerotic disease or heart failure. And if you have atherosclerotic cardiovascular disease, you can choose between a GLP-1 receptor agonist with proven cardiovascular benefit or an SGLT2 inhibitor with proven cardiovascular benefit. And if you have heart failure, an SGLT2 inhibitor, and alternatively, if GFR does not allow that, a GLP-1 receptor agonist with proven cardiovascular benefit. And as noted, we have also detailed how to improve management further, as I also alluded to, if this is not sufficient. With this, I thank you, and would like to proceed and invite the next, Walter Kernan and Gertrude Mengrone, to talk about therapeutic options for management.
Thank you, Peter. Our presentation excuse me, on therapeutic options has two parts. I will present the first, and Geltrude will present the second. Our disclosures are shown here. Our presentation will cover the full spectrum of antihyperglycemic therapy, including lifestyle, medications, and metabolic surgery. We want to point out, of course, that the foundation of therapy for hyperglycemia remains lifestyle, including medical nutritional therapy and physical activity. Medical nutrition therapy is a principal component of lifestyle therapy. It is usually defined as education and support to help patients adopt healthy eating patterns, and it has two components: diet quality and calorie restriction. In terms of diet quality, no single ratio of protein, carbohydrate, or fat is right for every patient. Instead, dietitians usually emphasize foods with known benefits, such as fruits and vegetables, and de-emphasize foods associated with harms, including those with trans fats added or high concentrated sugar added. Health education increasingly advocates healthy diet patterns that includes these foods, and some of these patterns have been shown to reduce hyperglycemia. An example is the Mediterranean diet. In addition to diet quality, weight loss through calorie restriction can be very effective for glucose control. Our consensus statement was influenced by 4 large, high-quality trials of calorie restriction in patients with diabetes, which are listed on the left. These trials include one or more combination of 2 basic types of intervention: support with intensive counseling and food replacement. In Look Ahead, weight loss was very substantial at 1 year, but weight regain affected the findings shown here at 9 years. The other trials reported only 1-year outcomes, but suggest that more weight loss results in greater fall in hemoglobin A1C. In the Jenny Craig and Direct trials, the fall was comparable to that reported with many oral drug therapies. This slide provides more detail regarding findings from the Direct trial. We wanted to bring this to your attention because it provided a remarkable demonstration of the potential for weight loss in diabetes remission. The trial randomized participants who had diabetes for less than 6 years to an intervention that included complete food replacement for 3 months, followed by gradual reintroduction of self-selected foods over 2 months, and then intensive counseling beyond that. The control group received usual care. After 1 year, diabetes remission rates were 4% in the control group and 46% in the remission group, in the intervention group. Average weight loss was about 1 kilogram in the control group compared to 10 in the intervention group. 2 of our consensus recommendations are shown here. First, an individualized program of medical nutrition therapy should be offered to all patients. Second, all overweight and obese patients with diabetes should be advised of the health benefit of weight loss and encouraged to engage in a program of intensive lifestyle management, which may include food substitution. Another component of lifestyle is intentional physical activity. For example, recreational yoga, swimming, other recreational exercise, walking. Physical activity can lower hemoglobin A1C on average by about 0.6%. Research in this area, however, shows that more activity is better for lowering hemoglobin A1C, that supervised activity is more effective than unsupervised activity. For those of you who like your trainer, that may be good news. Intentional physical activity has other health benefits for patients with diabetes, including a reduction in ASCVD risk factors, a reduction in fall risk, a reduction in weight, and an increase in bone density. Not surprisingly, therefore, our next recommendation is that increasing physical activity improves glycemic control and should be encouraged in all patients with type 2 diabetes. I will now discuss medications used for glucose management. This slide shows the most commonly prescribed classes of medications for type 2 diabetes. In the next several slides, I and Geltrude are going to discuss 4 of these in more detail. These are the agents for which we believe there is important new information that we wanted to present at this meeting. Regarding metformin, the advantages and disadvantages of metformin will be well known to this audience, and I won't go into them in further detail. Some other considerations we would like to point out include a widely accepted recommendation to not use metformin if the GFR is under 30, and to consider a dose reduction if the GFR is 30 to 60. In addition, metformin should be discontinued before administering iodinated contrast and avoided in hepatic impairment. The reason for caution in using metformin in renal disease is risk of lactic acidosis. Renal disease is a risk factor for this complication. However, lactic acidosis is very rare among metformin users, with an incidence that's estimated to be about 3 per 100,000 patient years. And recent information suggests that metformin can be safely used in patients with lower GFR than previously thought. In recognition of this new safety information, the U.S. labeling was revised in 2016. The FDA continues to recommend against use if the GFR is below 30, but now advises that it can be used cautiously for patients with a GFR above 30. Annual monitoring of GFR is recommended. Acting on the same information, the European Medicine Agency made essentially the same label changes, but provided more exact guidance on dose adjustment, as shown here. For patients with a GFR of 30 to 44, the maximum recommended dose in Europe is 1,000 milligrams. There are at least 15 available insulins and insulin combinations now, including 8 shown in bold that have been approved by regular authorities since the last 2015 consensus statement. The well-known advantage of insulin include the fact that it will lower glucose to any target when other agents fail, and it is effective at any GFR. The disadvantages include risk of hypoglycemia and weight gain, and the inconvenience of injection. Some therapeutic principles are listed here. Long and intermediate-acting insulins replace basal pancreatic insulin secretion and are preferred over shorter-acting agents for initial insulin therapy. Long-acting agents may have less hypoglycemia versus NPH. However, a paper by Kasielewska in JAMA this week suggests this may not be true in all clinical settings and raises a concern for all of us in this panel that all of our work will be obsolete in the next few weeks as new data emerges in our field of diabetes. Shorter-acting agents lower postprandial glucose and are typically added when basal long-acting insulin is not enough. Rapid-acting agents may have less hypoglycemia compared with regular insulin. Geltruda will now discuss the remaining medications, therapies, and metabolic surgery.
Thank you, Walter. Good morning, everybody. So, SGLT2 inhibitors include 4 agents sharing many advantages, including low risk of hypoglycemia and weight reduction other than blood pressure reduction. They reduce the progression of chronic kidney disease and hospitalization for chronic heart failure. And as shown before, cardiovascular benefits are increased with a progression from empagliflozin to canagliflozin. However, as any drug, they have also side effects, including genital mycotic infections, in particular in women, and possibly bacterial infection of the urinary tract, volume depletion, increase of LDL cholesterol, and for canagliflozin and ertugliflozin, also risk of amputation, and for canagliflozin increase the risk of bone fracture. However, the risk of diabetic ketoacidosis is indeed rare. Other considerations include that the efficacy falls with the glomerular filtration rate, and there is the necessity to adjust doses or avoid usage in chronic kidney disease. The glomerular filtration rate threshold and recommendations for use in chronic kidney disease vary for each specific agent. The benefits of canagliflozin have been shown in SUSTAIN 6 trial on major adverse cardiovascular events, however only in those patients with type 2 diabetes and with established cardiovascular disease. In fact, I'd like to put your attention on the effect of canagliflozin on MACE in the 2 subgroups. So, patients with prior cardiovascular disease who had hazard ratios of 0.82, which was significant, and patients only at high risk for cardiovascular disease who had hazard ratios of 0.98, which was not significant. GLP-1 receptor agonists include long-acting and short-acting agents, all of them sharing many advantages, including a low risk for hypoglycemia, in particular as monotherapy. They reduce weight, blood pressure, and cardiovascular risk factors, although also in this class of drugs there is a progressive cardiovascular benefits from liraglutide to semaglutide to exenatide extended release. And short-acting agents have more side effect, gastrointestinal side effect, than the long-acting agents. As all drugs, they have also side effects, including gastrointestinal ones, and increased heart rate, and in addition, as you know, they are injectable drugs. Again, the other considerations include the fact that the dose should be adjusted in relation to the glomerular filtration rate. There are also still some controversies regarding the GLP-1 receptor agonists, but our consensus can easily say that GLP-1 receptor agonists probably do not increase the risk of pancreatitis nor the risk of pancreatic cancer, at least in the short term. However, those patients with a personal or family history of medullary cancer of the thyroid or MEN1 shouldn't use GLP-1 receptor agonist. So, SGLT2 inhibitors in the oral route of administration drugs and GLP-1 receptor agonist in the injection class of drugs determine weight reduction, while biguanides and the PP4 inhibitors are neutral, and sulfonylureas, TZD, and insulins increase body weight. Regarding the effect on hypoglycemia, the only two classes of drugs, sulfonylureas and insulins, are associated with increased risk of hypoglycemia. Metabolic surgery, and the name derives from the rapid effect, metabolic effect of some types of surgery, which are observed long before a sustained weight reduction. Therefore, the name, instead of bariatric surgery, from Barius Greek, which means weight. Metabolic surgery is indeed recommended in those patients with type 2 diabetes and class 3 obesity, which should be an indication per se, so which means that morbid obese patients could be operated of bariatric surgery independently of the presence of diabetes. Or class 2 diabetes, so body mass index between 35 and 39.9 with a poor glycemic control. There are few true contraindications to metabolic surgery, and they include untreated eating disorders, untreated depression or psychosis, alcohol or drug abuse, and this is an important contraindication, so the inability of the patients to follow nutritional advice, which instead should be followed along their entire life. Metabolic surgery have many benefits, including high rates of remission of diabetes, in particular depending on the type of surgical procedure performed. They improve glycemic control and reduce the number of glucose-lowering medications. Of course, they determine a marked weight reduction, but also are associated to side effects, complications, in particular surgical complication, requiring reoperations in the 2 years after surgery, which are proportional to the difficulty of the operation performed. At 2 years, insufficient weight loss is pretty rare, while it increases over time. And also, metabolic surgery has late metabolic complications, including, but not only, iron deficiency anemia. So the consensus recommendation is that metabolic surgery is recommended as an effective treatment option for adults with type 2 diabetes and a body mass index higher than 40, regardless of the level of glycemic control, or in patients with a body mass index between 35 and 39.9, but with poor glycemic control in spite of lifestyle modification implementation and optimization of medical therapy. Please note that for patients of Asian origins, the body mass index is decreased by 2.5 points. So summarizing, the foundation of the hyperglycemia treatment in type 2 diabetes is for sure lifestyle modification. Also because those patients who are very well motivated and adherent to the indications of the endocrinologists and dietitians can achieve very good results. But we have also a pretty large medication portfolio when lifestyle modification fail to obtain, to reach the target of glycated hemoglobin. So a lot of choices. And we sincerely hope that in some way we made it easier to navigate among them. The choice of medication should be dictated by safety, efficacy, cost, and convenience. Then we have also another option, which is metabolic surgery, and which can be considered as an effective salvage therapy. I can conclude by saying that we have only two choices to obtain, however, disease remission: lifestyle modification and metabolic surgery. So thank you for your kind attention, and it's now time to introduce my colleague David D'Alessio and Chantal Mathieu, who will talk about strategies for implementation of our consensus recommendation. Thank you.
Thank you very much, and we are the last couple to go, and we've become such a Siamese twin that we decided to do it together. These are our disclosures. Just a reminder, we need to leave this up 6 seconds. Just a reminder, all the slides will be in a webcast for those people who came in late. So all the elegant ways to take sneakily pictures, don't do it. I mean, they'll be available for you. So the last bit is really, before we go into the gaps, is really how to implement now all of this in our day-to-day practices. And the first slide we wanted to bring back to you is this decision cycle for patient-centered glycemic management. Having the patient at the center of everything, keeping it clear that the goals of care are really prevention of complications, but also improving quality of life for our patients, is essential. Our patients need to be an integral part of the team. We need to start everything by looking at key patient characteristics, look at specific factors that may impact our choices of therapy, and David will explain this in detail, and then through a shared decision-making program, come to a joint management plan. A management plan that is not static, a management plan that should start, but then evolve together with the patient and be re-intensified all over. So David, up to you.
Thanks, Chantal. Let me walk through sort of our thinking on implementation. We recommend that metformin remain the initial drug to start patients with type 2 diabetes. And we actually debated this at some length. Metformin has been the recommended drug for more than 10 years when these guidelines first were started. There's been new data, and there's new alternatives, and there was a very nice debate at these meetings on Friday about whether metformin should remain the first drug for people with type 2 diabetes. However, in considering all the past and new data, we thought the composite of efficacy, safety, tolerability, and cost continued to weight our thoughts and make metformin the continued first drug of choice. 20 years hence, the UK PDS seems like a quaint and musty trial, but we still find that evidence convincing, particularly the reduction in diabetes-related complications in the context of being the initial drug started in patients in that study. Other general guidelines that we debated but really hewed to the old line was the notion that stepwise treatment was still where we thought most people ought to come down on. There's evidence now that initial combination therapy actually gives you a bigger initial drop in A1C, but we don't find yet evidence that long-term that makes much of a difference in terms of eventual outcomes. And the arguments against the polypharmacy, increased exposure to drugs, and increased cost of drugs that would come from recommending everybody start with initial therapy was one that swayed us. Nonetheless, most agents that you're going to start a patient on will only lower the A1C by about 1%. So if you see a patient who needs to be, who's higher than that, who's 1% or 1.5% above goal, one drug's not going to do it. And in that case, we would strongly consider combination therapy. Now, glucose-lowering treatment in type 1 diabetes has gotten much more complicated because there's many more agents, there's many more considerations. And so what we tried to do was put some structure, not strictly an algorithm, but some structure to the drug choices. My colleagues have already presented the view of the committee that people with cardiovascular disease ought to be considered up front. And the 20% of type 2, about 20% of type 2 diabetic patients with prevalent ASCVD would go into the first bucket, and they would have this treatment algorithm based on some of the cardiovascular outcome trials, as has been discussed. For the other 80%, we gave it order really by considering major drug side effects. And these two here are the need to minimize hypoglycemia and issues around therapies and body weight. And so these really swayed our judgment in terms of otherwise structuring diabetes care. And then finally, cost, which is a major adverse effect of drugs in the United States. This was an interesting discussion because a lot of our European colleagues don't face the sort of issues that American doctors have trying to find medical regimens that their patients can afford. But nonetheless, we felt like this was something that needed to be added to the algorithm, since only a minority of diabetic patients live in Europe. So to summarize this approach, the choice of medication should start with metformin, and then second medications should be added based on comorbidities, things like atherosclerotic cardiovascular disease, and then specific patient characteristics that you'd like to avoid, things like hypoglycemia and weight gain, and of course cost. The other recommendation is that this general strategy ought to be followed when you go beyond dual therapy. Because if the data for dual therapy is weak, going beyond dual therapy is truly the evidence-free zone. Nonetheless, in making sound judgments, things like adverse drug effects, overlapping drug consequences, and overall patient comorbidities need to be considered. Let me walk through the approaches that are not for the cardiovascular risk patients. But if you want to choose an anti-hyperglycemic medication and weight is a concern, and this is almost a fatuous title in that for whom is weight not a concern anymore. Nonetheless, there's a lot of patients where this is preeminent in their thinking. The thing I'd point out is that for all patients, when you're starting drugs or adding drugs, it's always reasonable to go back and consider lifestyle management. There's actually pretty good data that if you revisit lifestyle management at every stage in the therapeutic process, that you can get or regain some of its benefits. So advice on medical nutritional therapy, a consideration of medication for weight loss if you're facile with those drugs, and then metabolic surgery. All these need to be considered, I think, every time you reevaluate your treatment for patients. But for people who are either worried about more weight gain, because so many of the agents can cause weight gain, or who would like to lose weight, certainly these two classes of drugs, SGLT2 inhibitors and GLP receptor agonists, have been shown to give some weight loss. An average, say, of 3 to 5 kilograms, but rarely weight gain when you initiate these drugs. And so starting these in people in whom weight loss is a major concern is, we thought, a good choice. And then if the A1C remains above your target, to add the other one. Again, to remember that sulfonylureas, thiazolidinediones, and insulins tend to all be weight promoting. Now, the other side effect that we thought needed to be given sort of primary consideration when starting drugs is hypoglycemia. And, you know, identifying patients at particular risk, those with cognitive dysfunction or issues around competence or other drugs or bad comorbidities or just general frailty. Hypoglycemia can be a devastating consequence. Again, to select the drugs properly is important. Actually, to set the A1C target is important here too. Sometimes these people may not have the same goals that they would if they weren't as prone to hypoglycemia. But again, these classes of drugs across the top here, SGLT2 inhibitors, GLP receptor agonists, TZDs, and DPP4 inhibitors, essentially don't increase the risk for hypoglycemia beyond that you get with metformin. That is, it's a rare consequence. And so these would be the drugs that would be considered, and drugs like insulin and sulfonylureas that do cause hypoglycemia would be ones that you'd choose later or only in a pinch. Again, when you go beyond dual therapy, mixing and matching these sorts of agents is something that we all have to do. We all have to do it right now without sound evidence to guide particular pairings. And then finally, cost, because although nobody wants to gain weight and nobody wants hypoglycemia, the bottom line is the bottom line. And for some patients, the burden of expense is something that can't be overcome. This is our therapeutic algorithm, and although it's not glamorous, I think it's important to consider in a lot of ways. Those of us who have been practicing medicine for a long time know that you can get very good glycemic control with a combination of metformin, sulfonylurea, and thiazolidinedione. These are all relatively inexpensive in the United States and other parts of the world as well. But what's important is that these clunky old medicines have sort of slipped to the back. People aren't as facile with the dosing, with how to use them in an expert way. It's very important that these skills be maintained, because I think these are still important drugs, and it's also important that we pass along to our junior colleagues and trainees who aren't interested in these drugs, that never get into the New England Journal anymore, that they still have to be used, and you still have to know how to use them. With that, I'm going to turn it back to Chantal to finish.
So We have acknowledged the fact that GLP-1 receptor agonists can be a very good choice as second-line therapy, especially if cardiovascular disease predominates or if weight gain is an issue and you don't want hypoglycemia. But most of our patients in our regular clinical practices will prefer oral glucose-lowering agents. So when you need to move to an injectable therapy, what should you choose? And here, after a lot of debate, we thought that the evidence now is strong enough to say that in patients who need the greater glucose-lowering effect of an injectable medication, a GLP-1 receptor agonist should be considered as the first choice in people with type 2 diabetes. However, when on the basis of clinical characteristics like symptoms of catabolism, weight loss, etc., when you want to make the choice for insulin initiation as injectable therapy, then basal insulin is the preferred way to start. On what basis did we, and this was the basis of a lot of debate, but on what basis did we eventually make our decision? It was on the overwhelming evidence that GLP-1 receptor agonists give you hemoglobin A1C lowering in the same range as basal insulin, but can do so without hypoglycemia and with weight loss, in contrast to weight gain with most insulin preparations. And here we just show one meta-analysis where this is all brought together. So we also will provide guidance in our consensus document on how to initiate injectable therapies. So if you're not on target under oral glucose lowering agents, we propose that you initiate a GLP-1 receptor agonist. However, when you're already on a GLP-1 receptor agonist, or if the GLP-1 receptor agonist is not appropriate or insulin is preferred, the way to do it is to initiate basal insulin. And also when people on a GLP-1 receptor agonist are not well controlled, if not on target, we would add basal insulin to the GLP-1 receptor agonist. In people where you have a combination of a GLP-1 receptor agonist and a basal insulin, fixed ratio combinations that are now available of GLP-1 receptor agonist and basal insulins may be a good choice. If above target, despite adequately titrated basal insulin, what you should do is add prandial insulin, usually in a stepwise approach. However, we also wanted to have this in our consensus statement, namely that if you are a primary care physician, then at this level, when you want to add prandial insulins, you might want to consider specialist advice. If still above target, you want to move to the stepwise addition of mealtime insulins. So then you can go to a full-blown basal bolus regimen, or you can also consider using premix insulins. However, the more prandial insulin you add or using premix insulins, you will encounter more hypoglycemia and also more weight gain. And so with basal bolus regimen, we would for sure advise to seek specialist advice to manage these patients. What should you do with your oral glucose lowering agents once you have these injectable therapies? So patients who are unable to maintain glycemic targets on basal insulin, if they are on basal insulin, how should you intensify? Again, we propose the preferred way is to add a GLP-1 receptor agonist, or if in their oral glucose lowering therapies they do not have an SGLT2 inhibitor on board, to add an SGLT2 inhibitor. Another way is to add prandial insulin, but as said, once you start to do that, you have an increased risk of hypoglycemia and weight gain. So what to do with the oral glucose lowering agents? First of all, metformin. If your patient is on insulin, we advise to continue with the metformin. Sulfonylurea, if on SU, stop or reduce the dose by at least 50% when basal insulin is initiated. Once prandial insulins are in the mix as basal plus or as basal bolus or as premix insulins, we advise to stop the sulfonylurea. TZDs, we advise to stop the TZDs when commencing insulin. Why? Because of the fluid retention and the higher risk of heart failure. However, data are there to consider that lower doses of TZDs are still elegant ways to improve insulin sensitivity and will be able to mitigate the risk of heart failure in people already taking insulin. DPP-4s, here we would suggest to stop the DPP-4s as GLP-1 receptor agonists are initiated, because at the moment there is no rationale into combining these two incretin-based therapies. SGLT2 inhibitors, if they are already on an SGLT2 inhibitor, we would continue treatment. If they're not on an SGLT2 inhibitor but have reasons to be on an SGLT2 inhibitor, as this consensus statement proposes, namely having established cardiovascular disease or having heart failure, then we would suggest adding an SGLT2 inhibitor to the injectable therapy. Beware, diabetic ketoacidosis is rare in people with type 2 diabetes. However, in our clinical practices, we do have people with type 1 diabetes masquerading as people with type 2 diabetes, and so you do need to be aware that this may occur and that it will not be the typical hyperglycemic decay, but glycemias might be a lot lower than what you're normally used to. You need to instruct people on sick day rules, that they need to stop the SGLT2 inhibitors when they're operated, etc., like Geltrude explained. Finally, I will bring everything together. So, how should we now do it? The overall diabetes regimen should be based on patient preference and clinical characteristics. The basis is lifestyle intervention. The basis is multifactorial approach, taking care of all cardiovascular risk factors like blood pressure, lipids, etc., and is metformin. If there is established cardiovascular disease, if there is heart failure, this overrules everything, and you've seen how to do that with GLP-1 receptor agonist or SGLT2 inhibitors. However, as David said, the majority of our patients, fortunately, in our clinics do not have cardiovascular disease. But then again, other patient characteristics, in particular, the risk of hypoglycemia and the risk of weight gain, need to be taken into consideration. And so here, for hypoglycemia, we suggest SGLT2 inhibitors, GLP-1 receptor agonists, TZDs, DPP-4 inhibitors to be combined to metformin, and if not on target, re-intensify lifestyle measures and then combine with the other agents who do not give hypoglycemia. Very important here at the basis. If you do need to initiate insulin, choose the insulin preparations with the least risk for hypoglycemia, being basal insulin, and also take into consideration down tapering therapies. If you do have SU on board, if you do have insulin on board, and you have a patient who has a high risk of hypoglycemia, who is frail, etc., consider also down tapering your therapies with SU and with insulin. Weight, again, we took a stand that then SGLT2 inhibitors or GLP-1 receptor agonists would be the preferred drugs, with a combination of both if hemoglobin A1C is not on target, and again, the addition progressively of other agents. And then finally, we also acknowledged cost. And David, also in Europe, cost is an issue. So, access, treatment cost, and insurance coverage should also be considered when selecting glucose-lowering agents. So here we suggested SU and low-dose TZD, and again, if not on target, the combination of each. And here, again, I want to stress the importance of lifestyle and education programs, because with these agents and good education programs, teaching people about hypoglycemia, about weight gain, you can also get a long way. And so this is our overall picture. So it is actually, Dr. Inzuki, sitting on the first row, an adaptation of your algorithm, but we gave some guidance. And so this is what you will be seeing and will be open for your comments. But we want to end with this slide. namely the patient at the center of everything, and he should become an integral part of the team treating this patient. And so now we introduce Dr. John Buse for the final key knowledge gaps.
Thank you. Here are my disclosures of interest. I'm going to give it more than 6 seconds. So we thought about the gaps in our knowledge of diabetes, from pathophysiology of the disease to complications around therapy and around societal challenges for patients with diabetes. Obviously, this is not a comprehensive list, and as you comment on the guidance, certainly we would welcome other suggestions for attention. We can group the knowledge gaps into certain areas, and there are a number of areas where there's been ongoing discussion. The tools available to prevent and treat diabetes are vastly improved, but implementation of effective innovation is lagged behind and requires fundamental changes in healthcare policy and societal approaches to wellness. Our understanding of the basic mechanisms of disease have dramatically improved over the last 20 years, but in many ways have just taught us how much we still don't know. The management of overweight and obesity is clearly inadequate, and we need much greater emphasis on both lifestyle techniques, behavioral approaches, medication, and surgery. Though the benefits of lifestyle intervention and diabetes self-management, education, and support are clear-cut, we need greater efforts to understand how to better target these interventions and individualize these therapies for patients. Whereas everyone recognizes that preserving and enhancing beta cell function is critical to prevent diabetes or to prevent the progression of diabetes to a continually more complicated disease to manage, yet the approaches to preserving beta cell function are still underdeveloped. There's great promise from personalized medicine and the various omics platforms available, but to date we haven't fully developed those, and we need powerful approaches to understanding the potential benefits of these kinds of studies in the future. Clinical trials have taught us a great deal, but inadequately address the benefits and the consequences of medication therapies, particularly in subgroups of patients and in the population at large. We need more real-world evidence. The technologies available in that regard have improved dramatically over the last 3 to 5 years. And in clinical trials, we need, and in clinical practice, we need better instruments and more consistent evaluation of patient-reported outcomes. There remain fundamental questions about current therapies, and as Dave D'Alessio highlighted, I think it is arguable that metformin's role as foundational therapy is evidence-based, but at the same time we recognize that perhaps it's just a quirk of history. It's been available for a long time. If the world was different and SGLT2 inhibitors were the first agents that arrived in the modern era, it's equally possible that SGLT2 inhibitors would be the foundational therapy, and we would wonder if this new kid, metformin, really should move up the algorithm. I think there's tremendous interest in the SGLT2 inhibitors and GLP-1 receptor agonists based on the benefits shown in cardiovascular outcome trials. Those benefits are limited to the patients with established cardiovascular disease, and in none of the studies were the patients that were just at risk shown to have a significant reduction in the risk of MACE endpoints. We need studies to adequately address the question of whether these agents have a role in the primary prevention of cardiovascular disease. And as highlighted before, it is uncertain whether these drugs added together will provide additive benefit. It is possible that they won't, or that perhaps they could even neutralize benefit based on divergent effects on glucagon. Some of the classes of drugs that we have fall short of being ideal based on adverse effects. So it would be wonderful if we had insulin formulations and approaches that were associated with a lower risk of hypoglycemia or less weight gain. Insulin is obviously the mainstay of diabetes therapy in many patients, but as we've talked about, has limitations. The thiazolidinediones are remarkable drugs and the only substantial insulin sensitizers on the market, but they have their broad safety concerns from bone health to heart failure, weight gain. It would be a huge addition to our treatment portfolio to have safer or easier to use insulin sensitizers or better understandings of the benefits of low-dose thiazolidinediones. We recognize that the risks of low-dose thiazolidinediones are less. And lastly, we need better approaches and biomarkers for important comorbidities and populations. Non-alcoholic steatohepatitis is a major threat to the health of our nation and the world, and the current clinical trial paradigm requires biopsies, which create a huge burden on the conduct of these trials and on patients. We need better understanding of optimal approaches in the frail and older patients, and many of you are aware of the controversy recently about what the target should be in those populations and how best to define populations as frail and older enough that alternative treatment targets should be approached. Likewise, as highlighted yesterday in the RISE symposium, we have very little evidence of benefit of diabetes medications in adolescents and young adults, particularly with regards to the effect on the natural history of the disease. We really need to address this as a matter of urgency. And then there's the enduring questions that have been debated for the last 10 years in this guideline process. First, is early intensive combination therapy better? I know many of you advocate strongly for this point, but in fact, there really is not a substantial evidence base in that regard. Who really should get metabolic surgery? One might argue that most of our patients with diabetes would benefit from metabolic surgery. Clearly that's not a feasible or even desirable approach to management of diabetes risk in America. We need better studies in that regard, and we need better evidence regarding the benefits of continuous glucose monitoring and even self-monitoring of blood glucose in populations with diabetes. To address these and other vital clinical questions requires additional investment in basic translational, clinical, and implementation research. More time and cost-efficient research paradigms to address patient-centered endpoints are needed through regulatory reform and leveraging informatics and coordinated learning healthcare systems. The increasing burden of cardiometabolic disease in our society is an existential threat, and urgent attention to improve the prevention and treatment of these cardiometabolic disorders is of the essence. So to summarize the entire program this morning, the management of hyperglycemia and type 2 diabetes has become complex with the number of anti-hyperglycemic medications now available. We hope we have clarified a path, particularly for primary care providers, for global implementation, but particularly in the United States, North America, and Europe. Patient-centered decision-making and support and consistent efforts at improving diet and exercise remain the foundation of all glycemic management. Initial use of metformin, followed by addition of anti-hyperglycemic medications based on patient comorbidities and concerns, is recommended as we await answers to the many questions that remain. So, once again, we show this slide. You can take a picture of it, and we do invite you to contribute to the review process. The consensus paper, not the slide deck, has been sent to 20 individuals selected by our panel, and an additional 30 or so patients selected by the European Association for the Study of Diabetes and the American Diabetes Association. For those of you who write manuscripts for peer review, I'm sure you recognize the potential impact of having 50 reviewers for your manuscript. Nevertheless, we invite all of you, and you can certainly make this webcast available to your friends and colleagues if you share this slide with them. I would point out that that webcast is unlikely to be available until probably 2 days from now, on Thursday. It may come earlier. It certainly is not available now. You'll be able to submit your comments to adacomments@diabetes.org. You can submit those anytime you want, but after 11:59 p.m. Eastern Daylight Time on Monday, July 2nd, we will not be looking at them. Now, before you leave, we will have an opportunity for questions and discussion, but I do want to ask that if you are generally supportive of these guidelines, please let us know, because those that are not supportive are certainly going to let us know. And there is often the sense that, you know, we are completely off the rails because the people that complain, and the people that think this is pretty reasonable may not communicate that to us. So we'll leave this slide up here and invite people to the microphones for comments and questions. And once again, we really thank the American Diabetes Association, the European Association for the Study of Diabetes, and you for providing the comments now.
First and foremost, I want to thank John, Mel, and the entire committee for the outstanding job you've done. And I think you've taken at least the algorithm and given it some granularity and some tremendous guidance. So we will take questions. No criticism, Silvio. Only positive comments. But I want you to identify yourself and your academic institution.
So I'm Silvio Nzuki from...
We're trying to silence you, right?
Silvio Nzuki from Yale University. So I think you've done a spectacular job.
Can't hear you. Try it now.
Okay now?
Yes.
Okay. Silvio Nzuki from Yale. And I think the panel has done a spectacular job. I mean, it's just a tour de force in terms of incorporating all the new evidence that we've accumulated over the past 2 to 3 years. I had two comments, and maybe it's just a little bit of unclarity in terms of how the slides were presented. The first is that, and this is critically important, is that the initial step after metformin in those patients with CVD, I didn't see specifically if that decision was based on an inadequate control of hemoglobin A1C, whereas clearly the third step was glycemically driven, if you will, in terms of A1C above target and then add the third step. Was that purposeful? In other words, if I have a patient on metformin who's just had a bypass and the A1C is 6.5%, are we supposed to add an evidence-based therapy? Because that's not what the studies would suggest. I kind of agree with you, but it's not what the studies would suggest.
Silvio, I couldn't hear, but are you saying that after adding one of the two agents, SGL2 or GLP-1 receptor agonist, independent of what the A1C is? Is that what you're asking?
Correct. It seemed to indicate that if ASCVD was present or heart failure was present, that the drug should be added irrespective of the A1C, and I wasn't clear if that was intentional or not.
So Silvio, we weren't able to go into all the details of the figures, but in that figure, can you hear me now? No. Can you hear me now? Yeah, great, okay. So specifically we talked that if patients are not at target, then we would definitely add the second agent. If patients are already at target, then we would consider adding or switching or even looking at the target, because obviously the individualised target may not be appropriate and you may want to re-look at that. But that was an area, you're right, that we had quite a lot of discussion about, and it is clarified a little bit more in the figure.
And the second point is that I noticed that you gave a lot of attention to heart failure. It has a lot of real estate on the figure, which I think is really important. It was not clear to me if the SGLT2 was favored because it was on the top or on the left of the slide, depending on which slide you looked at, or if the GLP-1 would be acceptable in that circumstance.
So the SGLT2 is favoured, and we talk about those that have got evidence, but if the EGFR is not adequate to use an SGLT2, or a patient is not able to tolerate an SGLT2, we felt then that the GLP-1 would be a reasonable alternative.
And my last question is the
You only get two.
The CKD question does not enter, there's no decision node for CKD. And one might argue that the evidence basis for SGLT2s in CKD is as strong as it is for heart failure.
So I'm going to send that down to Peter, because we did talk a huge amount about this. So Peter, do you want to take that?
Well, I think it's a fair point to say that both outcomes were secondary. We felt that for heart failure we would make this a consideration recommendation, and for the kidney data we mention it and recognize that they are very important data. In both areas there are ongoing trials to resolve this, and I think they will be needed to make firm decisions and recommendations. So this is our standpoint so far.
Dr. Hahn?
Yeah, Philip Home, Newcastle. It's a strategic question, really, to you, Will, and perhaps to Chantal for the EASD. By the time you present on October the 5th, your evidence base will have been undermined on October the 2nd and October the 4th by two new big outcome studies. By the end of the year, 31st of December, we'll have a further two big outcome studies in the public domain. And next year we might expect perhaps the formal renal outcome studies to appearing for the SGLT2s, and a study which includes sulfonylureas long term. So listening to you, Will, saying we will do it again in 3 years' time, you're going to be in a frayed situation here. The document's not going to look up to date this time next year, indeed January. And could I appeal for you to think of coming back, making this a living document, coming back to San Francisco and telling us how you've incorporated the very significant new evidence by 6 months' time?
So let me just say, and I'll ask John and Melanie to comment, maybe anyone on the panel. This was something we faced with the standards of care, and with the standards of care, we've changed it to a living document to where evidence-based or event-driven evidence that you suggest can be incorporated throughout the year. With the consensus and the work we've put in, that is something we'll have to take to the drawing board and discuss with the EASD, but honestly, wow, see, the lights went on when I talk, right? It's easier for one organization. We did it for the standards of care, but the amount of work that's gone into this is something that we can talk internally. I don't know if this group wants to work 24/7, 365 to continue to update it, but your point is well made. And again, there's been so much information in the past 3 years. I think what the committee done is unbelievable. But maybe we can consider updates to the document, and that's something that we haven't considered, but John, you have some thoughts?
Yeah, I do think it's important to remember.
Talk closer to the mic we had.
I do think it's important to remember that this document is not the policy of the EASD or the ADA. It's a consensus report, and aspects of this report will be incorporated into the ADA standards of care, as an example, and that is a living document, so it could be quickly updated. I think I would speak for most of the panel members if the ADA and EASD saw fit to enable us to get together, maybe not with fortnightly telephone calls. We've actually quite enjoyed getting to know each other better and debating these topics, and you know, I'm happy to visit London again.
John, a great job. Thank you.
So Phil, what we can do is, again, do the similar mechanism we did for the for standards of care, and we'll consider updating or annotating, updating the document as we go, but that's something we hadn't considered yet.
It's such a great job. It has to be kept up to date at least 12 monthly.
Well, we expect an email from you in support, okay?
Jennifer Wyckoff, University of Michigan.
Can you speak up? I'm sorry, we're having trouble with the mics.
Jennifer Wyckoff, University of Michigan. I want to thank the panel for all their hard work, because I can understand how difficult it would be to grapple with all of these different competing pieces of data. I actually have 3 questions/comments. The first one is, there isn't a box in the big algorithm for people who are losing weight or who are underweight or who are normal weight. And I'm concerned that with the push for SGLT2s for cardiovascular reasons, that there will be people who will get put on SGLT2s who are actually developing LADA or type 1 diabetes, or have pancreaticogenic diabetes that's being called type 2. How much is there in the consensus statement about screening for that type of diabetes and protecting that group of patients? Because I'm afraid that this is going to be widely used by primary care doctors, and they may not be thinking that. So there should be some statement in there making sure that that's highlighted. Chantal?
Yeah, it's taken. So it is taken care of in the manuscript. So you will see there is a statement that if you have a person who is not phenotypically typical for a type 2, you need to think of other types of diabetes, MODY, type 1, etc. So we couldn't show it here, but and also we made a clear statement also in the figures that if you have symptoms of catabolism, you know, if you're losing weight, etc., that insulin is the therapy to think of.
If it's in the figures, I feel much better, because that's what people will look at. My second question is there a recommendation on how frequently to reassess the hemoglobin A1C? There are many steps here of medications, oral medications and injectable medications, that have the ability to lower the A1C 1%. Because there are so many steps, I'm concerned that if there is a long time period between reassessing the A1Cs and the efficacies of each step, a person may have an A1C of 9.5 for 3 years before they get to an insulin dosing. And it's not that I disagree with using these oral medications, I'm just concerned about the clinical inertia that somebody mentioned quite appropriately in their talk.
So I think that's an excellent point, and we do focus quite a lot in the manuscript around clinical inertia and ensuring that. But you're right, we probably, I think it is referred to in other documents, but we probably need to add a little bit more detail around the frequency of the steps. Thank you.
And there is specifically a statement, I don't remember the cut point that we decided exactly, but I think it was 1.5% above the target that you could or should consider insulin as initial therapy.
Thank you, John.
Can I, to be fair, let's go around and maybe you could write that one to the AD. Or if we have time, we come back around. I just want to be fair to everyone else in the room.
Thank you.
Alice Cheng from Toronto. So congratulations to the panel for a fantastic job. I only have one question. In the context of this day and age where we know language matters, I would argue that language matters not just in how we interact with our patients, but also how we interact with each other. Any thoughts about changing the terminology of intensification of therapy to something else? Because I wonder for the larger community, not the folks sitting in this room, but people, the other people who manage diabetes, the concept of intensification, it's a harsh word, and that may actually be one of the barriers to people actually doing things, where in fact we're not intensifying, we are finding the appropriate therapy for that patient. So just a food for thought for the panel as you're writing the document, whether you may want to make a comment about that.
Thank you. John?
John Yudkin, London. A really nice bit of work, and I think that the Guidelines Committee have made progress on the two areas that I've got some comments about and asking for clarification. Firstly, patient-centered and shared decision-making. I think it's a very patient-centered document. Is there enough apparatus for shared decision-making? The last ADA guidelines were criticized because shared decision-making tools weren't adequately included, and even the information wasn't adequately provided. Mostly data were down there as relative risk reductions, meaningless to patients, even numbers needed to treat, problematic for patients. Victor Montori has produced some really nice shared decision-making tools, and models have been created that can turn even the recent drug outcome trials into quality-adjusted life years gained. And I think that when that's done, and Elbert Huang's done it, we've done it, the Oxford team has done it, what surprises people, clinicians and patients, is that even the new drugs are providing less than 2 months of quality-adjusted life year gains when clinicians make estimates of 7 years. So could I make a suggestion that if you haven't done it, you should include shared decision-making tools? The second point of clarification is about conflicts of interest. I think you've gone a good long way to improving how this has been done, but I'd point out the Institute of Medicine recommendations from 2009, which include there should be a majority of people on any guidelines committee without any conflicts of interest. B, the two chairs, the chair or chairs should have no conflicts of interest at all. And C, an inclusion of a methodologist on the board, a panel as well as the clinical experts is a recommendation. What's a little bit concerning is on the ADA app, one of the two chairs is listed as being a board member for 7 pharmaceutical companies. I'm trusting that's a misprint for advisory board member, because at the conflicts of interest industry academic symposium a couple of days ago where John Buse was there, an academic lawyer from Harvard pointed out that if you are a board member of a company, your duty is no longer to the patient. You have a fiduciary duty to the company, which overweighs everything else. So could I suggest that if the board member was a misprint, it wasn't on the slide, that should be carefully edited before you finally produce it?
No one up here is on the board of any company that I'm aware of.
Thank you.
John, let me just say that the majority of the committee, we look very carefully at this between the EASD and the ADA, and the overwhelming majority of the committee does not have conflicts. And honestly, I was in that decision to have John as chair to provide continuity from the previous session to this one. But we have adhered as much as we can, and we understand that completely.
And a methodologist for inclusion probably next time around.
So Apostolos has, I think, great experience in terms of evidence-based medicine, so he was almost our methodologist, I think, in terms of that regard.
Thank you, John. Jane?
Jane Roosh, Denver. I had One question, a bit related to the shared decision-making tools and a bit related to behavioral therapy. There was a lot of discussion about diet and food intake recommendations, but it was a little bit superficial on the exercise component and physical activity increasing component and tools to reinforce that and facilitate that. So I am hoping that that section will be robust with a number of strategies, alternative strategies, and DSME type of things to support that.
So we didn't have time to present all of the data that's in the manuscript, and physical activity, I think we have a section on physical activity which I think is fairly comprehensive. There's another table that we didn't have time to show which talks about the cardinal components of structured self-management support. So I think if you read the whole manuscript, there is a bit more, it's a bit more balanced.
And my understanding, Jane, is as an executive committee member of the ADA, you will be getting this manuscript very soon, and we would certainly invite, detailed comments in that regard.
And then I just have a question as to what is the evidence base that obliges in patients without any evidence of renal disease, annual GFR or creatinine for people on metformin?
I don't know that there's an evidence base. It's a regulatory request of the FDA. It's in that website, is my understanding.
It just practically speaking can lead to interruption of therapy in closed-loop systems.
Thank you. So again, if you can make your comments short so we can continue to go around.
Serwan Vertical from Chicago. So thank you so much for the presentation. I have some question or suggestion regarding cost-benefit analysis of some of these newer medications. So I practiced in an inner city, very disadvantaged population, very bad insurance. So many times insurance does not have any of this cardiovascular benefit medication even on the formulary. And I would definitely say no, unless you have the nurse and has time to go back and ask for prioritization over and over. They are not getting any of these approved medications. And or sometimes the insurance will put it in but make it like very high tier so the patient cannot pay for it. So I wonder if there's a way to add the cost-benefit analysis of some of these heart outcomes, renal outcome or cardiovascular outcome, so that it would be worth paying for this medication to prevent these heart outcomes in the long term, so that perhaps the insurance company would consider this when they're thinking about approving the medication on their list. Thank you.
So I just a comment to your comment would be that we did include in the wheel cycle that obviously if a patient can't afford a recommended therapy or provides pushback in that regard, that would be a compelling reason not to move forward. No drug can benefit a patient if the patient can't take it. The second thing is we did discuss doing more formal cost benefit kind of analyses and decided that particularly for a document that would be used in the United States and in Europe with many different healthcare systems, it was just an impossible task. I do think the American Diabetes Association or some U.S. organization could try and do that for the U.S., but even in the U.S., what is the cost of a drug? It's one of these hugely debated issues, and I would defy you to tell me what the cost of a drug is.
So again, to the right, we just have a few more minutes. Yes,
Ron Goldenberg from Canada. First of all, congratulations to the entire panel for putting together an excellent, comprehensive, evidence-based algorithm. There are many guidelines and algorithms out there, and it was nice to see that your manuscript and algorithm really harmonizes quite well with the Diabetes Canada 2018 guidelines that were published in April of this year. And In fact, it's nice to know that if my patient in Canada moves now to the United States or Europe, that they'll be treated in the same fashion. But I just bring that up because I wonder if there should be an initiative to have guideline committees internationally around the world meet periodically to make sure that the guidelines are harmonized around the world, and perhaps an initiative should be done to get that going.
I would just point out that we did specifically review your excellent guideline as a group, and thank you for that that comment. Will?
I'm just going to comment and just say that there are 3 additional exercises going on now with guidelines, not only with the ACC, ADA, but ADA, EASD, and actually we're trying to work with endocrine and reach out to ACP. I would like nothing better to make sure that guidelines are at least agreed upon among many organizations, but that's easier said than done. I'd say at this particular point there are several organizations that have reached out and want to see what we can do, but again, there are 3 ongoing paths now with ACC guidance and glycemic control, the ADA, EASD, and ADA, which we're at least trying to harmonize those 3. And again, endocrine has also reached out to us regarding this. Let's go to the last 2. We just have a couple of minutes.
Hi, I'm Naresh Kanimili. I'm a GP in Manchester. Quick question. Dara mentioned the C word in a room full of Ds and Es. The cardiologists have they had any input into this at all? Because we are now debating whether these drugs are actually cardiological drugs or diabetes drugs. So I think we're doing something in Manchester, but we have had cardiologists on board. So I just want to question about that.
Let me answer that, because part of the reviewers we chose are part of the other processes that involve cardiology. We're working with cardiology groups, and again, we each had decisions on what reviewers and what groups we're going to send, and so we've actually having those individuals, cardiologists, review some of these guidelines. And there's a lot of overlap between this committee and the other committees, and we make sure there's good cardiovascular expertise on this. So we have cardiovascular guidance in our standards of care, the ACC input, and so there's a lot of input coming in from cardiologists. There's some resistance, but we're going to work with the cardiologists.
We found that in Manchester when we opened this up to the junior cardiologists, they just didn't want to know. They said it's an endocrinology problem.
We welcome cardiologists into the diabetes world.
Okay, that's good.
Yes.
Al Powers, Vanderbilt University. Cost. So you set aside cost of people who don't have insurance, but there's cost of all of these medications to each company, each country, each of us as a society. So I would ask you to talk about your decision to set cost aside only for a select group of people, as opposed to the societal, company, personal cost of drugs in general.
Al, can I take that? So Al, I mean, that's a fair point. If I made it sound like cost was only for the uninsured or the
But you said cost where cost was a consideration, and I would argue that cost is a consideration for everyone. If I'm a health plan, if I'm a country, if I'm an organization. So I just, the assumption that cost is only a concern for a select group of patients, I think needs to be given some more thought.
So I think the problem is, though, that it's not just the cost of the drugs, it's the cost of hypoglycemia, it's the cost of
but I'm just saying, and I understand that John is going to say, well, how do you know how much drugs cost? But I'm just saying, to me, it takes cost out of the equation for all of those groups, but to me, it's cost. It's really about value, right? That's what we're talking about. What's the medication value of that? Dr. Buse, do you want to say something?
Yeah, just to be absolutely clear, what that branch point says, if no such needs identified or cost is a major issue. So you could get there because there's not a compelling need to deal with cardiovascular disease, obesity, or
But John, my point is that cost is a concern for everybody who pays, not just for those, not that individual. I'll stop.
In the final section, there is also a discussion about cost and access of care being major issues in society. But we'll make sure that that's adequate.
If it can be quick, this has to be the last question, because I know that some of the speakers have to go to additional sessions. Quickly?
Yeah, very quick. Emma Jekyll, Hanover Medical School, Germany. Congratulations. I think especially your decision to make GLP-1 the first injectable was long overdue, but it's a revolution in diabetes medicine, I think. You put a lot of emphasis on cardiovascular disease, and perhaps I didn't see it on your list. When it comes to the insulins, I didn't see any distinctions between the insulins, but at least we have 2 cardiovascular outcome trials and show that some of them are safe. And this, I think, should be...
So the problem is that the footnotes were a little small, and there's a bit more detail in the figures that we weren't able to show today around insulin management, and it's also in a table that we have in the manuscript that we weren't able to show as well.
Okay.
So again, thank you for coming, and again, I want to thank the committee for the incredible work.